Good morning and welcome to the Houston Methodist DeBakey Cardiovascular Grand Rounds this morning, and also welcome back on the George P. Noon conference this morning. And when we earlier, a few minutes ago, we had talked about the agenda for today, and as mentioned, our keynote speech for the George P. Noon conference is also combined with our grand rounds this morning, and it is my pleasure and honor to have Dr. Mandeep Mehra as our keynote speaker for the George P. Noon conference and for our grand rounds. Dr. Mehra is the William Harvey Distinguished Chair in Advanced Cardiovascular Medicine and Professor of Medicine at Harvard Medical School and the Executive Director of the Center for Advanced Heart Disease at Brigham and Women's Hospital in Boston. He also served as a founding medical director of the Heart and Vascular Center at the Brigham and was editor-in-chief for the Journal of Heart and Lung Transplantation, which really rose to the #1 ranked journal in our field under his leadership from 2010 to 2020. Dr. Mehra is the only individual to have been appointed as the president of the International Society of Heart and Lung Transplant and the president of the Heart Failure Society of America, two premier societies in the field of advanced heart disease. He has authored over 500 scholarly papers with a specific focus on advanced heart failure, and among some of his highlights of discovery for our field were the obesity paradox in heart failure. He described the natural history of cardiac allograft vasculopathy after transplantation and also established the pivotal international guidelines for selection and care of transplant patients. He defined the role of new immunosuppression to improve transplant outcomes and also helped introduce genomic-based biomarkers for evaluating cardiac allograft rejection. Basically defined our field. That's how I look at it. But Dr. Mehra recently in his leadership has really led the field of mechanical circulatory support, and under his leadership, the Momentum trial, which set the landmark improvement in outcomes for HeartMate 3, and his ongoing contributions will shape the future of mechanical circulatory support. And really, Dr. Mehra is one of the leaders and inspiration for a lot of us in this field. He's also he has a certificate in executive leadership from the Harvard Business School and completed a Master's of Science in Health Economics and Management at the London School of Economics, a degree earned through his designation as Braunwald Scholar. I can probably give a grand rounds on his accomplishments, but we're really elated, and at a personal level, Mandeep's a really humble gentleman who's been a mentor for so many in the society, and I'm privileged to kind of share his friendship outside the professional world. And Mandeep, thank you so much for being here, and welcome virtually. I hope we can get you here in person soon. I know you had visited in the past, and but the pandemic world limits us from that. So thank you so much for here, and I'll hand over to you.
Thank you so much, Arvind. What a fabulous introduction. I'm very, very grateful and greatly humbled by this honor to speak to you all today in what I understand is a combined conference, a cardiovascular grand rounds, as well as your conference that is shaping the education in the field. Arvind, thank you again, and thanks to the leadership of the institution for the invitation. The task that you've given me today is to discuss with you the future of mechanical circulatory support, the needs and what's still to come, and I hope to do some justice to that. But I want to begin by introducing the concept of the life cycle of device innovation, which has been a issue for us, and just well known to us is the status of technology such as, say, cars, for instance, where there is, in fact, a life cycle of device innovation. And we are, of course, seeing a paradigm shift in cars from combustion engines to electric vehicles. And we have seen a few paradigm shifts that typically begin with engineering, the creation of a prototype for a mechanical circulatory support device, the preclinical and clinical application, the manufacturing, marketing, commercial use, and then we have the real world experience that then defines the risk analysis and the benefit of individual devices. And then there's an end of life. And we must know that with each device that comes in, there will be a start and a finish, and they will move into obsolescence at some time point. And that is usually our hope, because with each device moving into obsolescence, there is in fact a much brighter future for our patients. Now, the evolution of mechanical circulatory support devices saw one important paradigm shift, which to a large extent was created at your institution, the concept for the transition in large, bulky pulsatile devices from the 1990s to where we saw small continuous flow pumps such as the HeartMate 2 and the Heartware HVAD were really generated from science that came from the Texas Medical Center and your institution and colleagues who have really been at the forefront of this. And so you are not naive to this evolution because you created it. But it is important to realize that the technology really has shifted from large technology to small technology. The number of moving parts has gone down to very few, and the profiles have become so small that they have allowed for application in many ways that we could not hope to apply the larger devices. And to some extent, we've drawn inspiration from space technology in doing so, in moving to almost rocket propulsion technology. Now, Joseph Stellick and Jim Kirkland wrote what I consider to be a very thoughtful perspective piece recently on the long and winding road to LVAD innovation. And this particular perspective piece outlines how difficult it is to, in fact, introduce mechanical circulatory support devices. And that shown here in this schematic drawn from that paper is the fact that there were and have been a number of different devices that have been introduced, including the Micromed DeBakey heart device, heart assist device that's shown here. And many of them have had a run with very few actually reaching real world use and commercialization. And even in that, we recently saw in June, we saw the movement to obsolescence of the HVAD or the hardware device, which was withdrawn from distribution and manufacturing just a few months ago, which really was quite a shock to the field, leaving right now an accidental monopoly in the HeartMate 3 pump, which we'll talk about in a moment. Now, why these devices come and go and what is the Achilles heel for these devices is the notion of hemocompatibility. And hemocompatibility is essentially defined as the interaction between this artificial heart pump support and the interface of the native biology. And when you think about it, it really is a balance between hemostasis and thrombosis. And one central part of it is the creation of acquired von Willebrand disease that we see developing with this very low pulsatile flow, or what we call continuous flow, with the newer generation devices. But as you think about this, most of the devices challenge us with three things. The first is de novo thrombosis. So the devices can either ingest clot or they can, in fact, generate enough heat within their rotors that they can generate clot de novo. And this has been largely a problem with the HeartMate 2 and was less of a problem, but still a problem with the Heartware HVAD. A second issue is of neurologic events. And in fact, much of the demise of the Heartware HVAD was directed towards this particular complication from a hemocompatibility standpoint, where we see a number of neurologic events with these devices. And finally is the direct link to acquired von Willebrand disease, which is gastrointestinal bleeding that appears to be on the interface of AV malformations. And in fact, this continues to be the biggest challenge that we have in the opportunity to reduce the risk in hemocompatibility at this time point. And if we have time, I look forward to discussing this issue with you. Now, the HeartMate 3 was designed to overcome all three of these issues. And it was created in such a way that it's based on a fully magnetically levitated platform with wide blood flow pathways, both primary and secondary blood flow pathways. And the idea was that it should not cause de novo thrombosis. That was the primary reason. And in fact, in order to support that, the engineers created an artificial pulse algorithm within this device, which is a fixed dysynchronous or asynchronous pulse that allows this device to ramp up and ramp down at a rate of 30 beats per minute. And in fact, in the pivotal trial, the Momentum 3 trial, which Dr. Bhimaraj mentioned earlier, which included over 1,000 patients randomized to the HeartMate 2 or the HeartMate 3, we were able to show superiority of this pump directed towards these hemocompatibility-based outcomes. And in fact, as we look at it, there was evidence of near elimination of pump thrombosis. There was marked reduction and halving of stroke rates, both ischemic bleeding and disabling strokes. And there was a marked reduction in bleeding, but it was the least component of reduction. We looked at another 1,685 patients beyond the trial and compiled the data from 2,200 prospectively initiated HeartMate 3 pumps and recently published that data in the European Journal of Heart Failure, and were able to show that the early observations within the trial actually met their observations in the phase 4 phase of this experience. And in fact, we included sicker patients during that time point with similar to slightly better outcomes. In fact, the net burden of complications was lower and the hospitalization rates were lower, bringing us closer and closer to cost effectiveness of this therapy. As we look into the future, there are at least three intertwined challenges from my perspective. The first relates to the need for advances in engineering. The second relates to how we clinically apply these devices. And the third that I will discuss briefly relates to health system issues that allow for the appropriate application of such devices. And these are three intertwined challenges that without one, the other hydraulic does not really work very well. So let's first address the issue of engineering. And in engineering issues, I consider the challenges to our engineers and our bioengineers the big three. The first is direction of flow. And I will tell you what I mean by that. The second is the introduction of pulsatile and smart circulation. And we'll discuss some of that in a moment. And the third is that while we have devices that are much more forgiving at the moment, they're not necessarily forgettable as we would like to see, because the driveline still continues to exit the abdomen and connect to the battery console. Now, there are a number of LVADs in preclinical phase evaluation that we hope will be introduced within the next 2 years clinically in humans. For example, one which is being developed at a site near you in the medical center there is a device called the Torvad. And there's some very unique characteristics of this device. It actually has a extremely low RPM. It runs at an RPM of about 150 to say 200 RPMs because it uses a dual piston approach in its mechanics. It has low shear stress and allows for synchronous pulsatility and may in fact be another more hemocompatible device. And this is remains to be seen how this is applied. The second is a device called the Corewave device. And the Corewave device is another interesting device where instead of a moving part like a rotor, it actually has a moving part like a fish tail, where this device, in fact, moves blood, again, with a synchronous pulsatile algorithm. This device has the ability to either pulsate in a co-pulsation modality with the heart or in a counter-pulsation modality with the heart. The one issue with this device that I can see is its slight bulkiness. It's about 1.5 times the size of the HeartMate 3, so that may pose a bit of a challenge in terms of minimally invasive implantation, but nevertheless, it is very interesting to see these sort of new engineered devices with different ways of mechanics to help us move forward. The problem, though, that I see even with these devices is in the direction of flow. So when we place the left ventricular assist system, we place it in the left ventricular apex. And in fact, what we do is we change the natural flow, which is a trans-aortic flow, to a transapical flow, as a result of which we create a worsening of the conditions in the unsupported ventricle or the right ventricle. This is what I mean by direction of flow, and we may in fact have to reconsider how we implant these devices and what kind of a flow algorithm is introduced. Why does the right ventricle fail? Well, as you create this particular transapical circulation, there is a mechanical dyssynchrony on the septum. And the septum, as most of you know, accounts for about 40% of the right ventricular forward flow. And when this mechanical disruption occurs, the right ventricle, which has already been stressed, as we'll discuss in a few moments, with contractile insufficiency from a number of different factors, becomes largely more dysfunctional. And this has been shown even in the stable phase, that as you keep on increasing the speed of the LVAD, the right ventricle starts to dilate. And this was shown very nicely with 3D echo imaging by Nir Uriel and his group very recently. Now, as we think about the right ventricle, we should focus on right ventricular performance and ask ourselves, is it really resistive loads that are problematic on the right ventricle when you have a partially supported circulation, or is it pulsatile loads? So, for example, resistive loads include the loads like a transpulmonary gradient or a pulmonary diastolic gradient. And we think of resistive loads as pulmonary vascular resistance. And it turns out that these indices perform rather poorly with prediction of post-LVAD RV failure. So it is very, very difficult to predict the onset of RV failure after implantation just by looking at PVR. In fact, PVR comes down after we place an LVAD. It is, in fact, pulsatile loads that are related to pulmonary compliance and to contractile insufficiency of the RV and the mechanical dyssynchrony of the septum that really account for the dissociated performance of the RV after we provide left ventricular support. And one easy way of looking at pulmonary arterial compliance is to look at the ratio of stroke volume to the PA pulse pressure, which is PA systolic minus PA diastolic pressure. And in fact, this may emerge as an important way of looking at pulsatile load. Right now, we look at pulsatile load in the form of PAPI, or pulmonary artery pulsatility index, which too gives us some insight, but there are challenges with the quality and quantitative aspects of this particular issue. So the RV performance can generally, if one has to judge the performance of the RV going into an LVAD, one can look at the central venous pressure or RA pressure to wedge pressure ratio. One can look at the pulmonary artery pulsatility index and RV stroke work. But again, the performance of these in terms of true predictiveness is quite poor. Why is it quite poor? The reason it's quite poor is because at the time of LVAD implantation, it's not just the hemodynamic configurations that are important, but we see things developing such as hypoxia and acidosis, prolonged bypass time, the need for blood transfusions, dilation and increased volume of the RV, worsening tricuspid regurgitation, hepatic renal changes, increased inflammation that further suppresses RV function. And then, of course, the pre-existing myopathy of the RV itself becomes manifest. This is why it has been extremely difficult to predict which patient requires right ventricular support, albeit temporarily, versus those that do not with an LVAD. And I consider this an engineering challenge to a large extent because it may be important to think about the way to protect the RV might lie in the way in which we flow the circulatory dynamics in the LVAD. We'll come to that in a moment. Now, one attribute of surgical involvement includes the avoidance of a central median sternotomy. And if you can, in fact, get by with a minimally invasive implantation, folks have argued that the risk of right heart failure could be mitigated a bit. Well, I'm not so sure about this issue, and I'll be happy to discuss it with you because in one of the best and largest propensity-matched analyses of this, there has been a signal to reduction in right heart failure, but there has been no impact on outcome in the long term. This tells me that perhaps this represents selection of patients rather than a true ability of this surgical technique to mitigate the onset of right ventricular dysfunction. And this is why we, in fact, have a multitude of challenges on our hands, and different configurations of temporary mechanical support for the RV have been entertained. When we look at the Momentum 3 trial itself, the rate of right ventricular support requirement is about just under 5%, which tells us that while right ventricular dysfunction is quite common after a left ventricular assist device placement, the need for support may be less common, and clinicians are smart enough to get patients through this. But yet you can imagine that the persistence of right ventricular dysfunction is not necessarily what we want to see happen because, as we'll discuss later in this talk, there is a challenge that is posed by right ventricular dysfunction on the entire concept of myocardial recovery with hemodynamic unloading with an LVAD. Now, for those patients who need biventricular support, there are at least two very interesting emerging technologies that are out there. I'll point out the CarMate device first. This is a fairly large, bulky device, and so only fits into large men and is not easy to fit into women, but has been done successfully. This device has two very interesting features from which future LVAD technologies could possibly learn. The first is that it has not just a hemocompatible, but it is designed with a biocompatible interface. And how that can be utilized in future iterations of left ventricular assist devices remains to be seen. The second thing about the CarMate device is that it's a physiologically smart pump. So it varies its auto-regulatory features in response to preload and afterload. And this is certainly something that is missing from the current generation devices. When you look at the other device, the BivaCore device that I've shown here for you, I'm intrigued by this device because this has two very interesting features. The first is that it's rather small. It can fit in the probably your palm. And this gives this device broader applicability if it works out. The second issue with this device is that it actually uses a single moving part, which compartmentalizes right and left flow. Now, there's phasic dissonance between the right and the left in this device, and it remains to be seen how that will actually work in the human model. But it's a very, very intriguingly engineered device that we should stay tuned for. Now, this brings me to this issue of physiologic flow, which is transaortic flow. And there is now a device in development. It's very much in preclinical development, and we have no idea where this device will go and whether it will actually even reach humans once it passes its preclinical phase. But this is a physiologic flow pump and is a smart pump. Why? Well, it's implanted transapically. However, its flow is transaortic. And what that means is that it allows for that buttressing effect between the right ventricle and the left ventricle on the septum and does not induce septal dysynchrony. Its challenge with this device, which is pulsatile, capable of smart interface and physiologic changes, is that it is intraventricular, and therefore sizing, positioning, sustained direction capability, etc., will become questions that we have to answer as this device is developed. It's currently called the ICOMS device, and the sponsor calls it a flow maker for sake of a better word. But it certainly is a fully implantable device, and there are two other possible benefits. The first is that it has no outflow. It doesn't need an outflow because its outflow is directly transaortic, obviously. And so it has smaller parts. It doesn't have the challenges of a outflow graft that could cause a problem. And the second is that because its power requirement is much lower, so instead of fighting with the circulation and changing the direction of the circulation, it's only assisting the circulation. It may, in fact, be able to get through with a fully forgivable and forgettable interfaces in terms of powering the device in a much better way than other devices can that require and consume a lot more power. Now, interestingly, I do want to point out that there are a number of what we would call biomimetic, non-blood contacting surface devices that are now being developed, at least in some laboratories. I'm not so certain that they will reach the human model very quickly, but it's important for you to know that folks are thinking about unique ways of powering these devices in a sustainable manner. If you remember, we used to use myoplasty in the old days using the latissimus dorsi muscle and wrapping it around the heart. And of course, because of skeletal muscle ossification, that didn't quite work in the long run, and it wasn't something that became a true internal LVAD. However, some folks in the laboratory are looking at using this as a means of sustainable regulation and powering of devices. And some of these devices are external devices that may not contact the blood surface. Where this field goes, I have absolutely no idea, but I do want to point out to you that there are intriguing engineering thoughts that are in play in our field at this time point, for which we should remain very optimistic. And then I want to point out for you another group of devices that we are now seeing introduced already in humans, which are not really VADs, but they are CADs. That is, they're circulatory assist devices, because they are typically implanted in the descending aorta. Right now, they're utilized for temporary support. However, in each of these iterations, shown from the left is the cardio bridge, the middle one, the procerion, and the right, the second heart assist device. They have different names, different ways in which their propellers work. But each of these devices are being configured, as far as I know, into sustainable devices that can be left in and powered in the descending aorta. Why might this be important? Well, this may be important from a cardiorenal a standpoint where we could overcome the congestive features of heart failure. And they may be equally important in patients who are not necessarily suffering from contractile reserve issues, such as with the HFpEF, for instance, and who are in severe heart failure. So this device group, in my viewpoint, is a very, very important near future a device group that we should pay very close attention to. And I suspect that you already are exercising leadership at the Methodist Hospital in this regard, because I know you're always in the forefront of such technology. Let's shift gears for a moment of time and think about the challenges of clinical application, because engineering is one thing. And so far, our focus has always been on evaluating different engineered devices. But one of the biggest challenges that we have is in the evidence-based and in the non-evidence-based aspects of clinical application of these devices. For example, we have a number of issues with implantation timing. We have a number of issues with surgical implantation techniques. We have post-implant issues with pharmacological therapy, and the fact that we have no evidence with pharmacological therapy driving us in the post-implant phase, and the fact that there is a lack of ability to harmonize our ability to detect complications from these devices. Some complications which can be quite silent, like outflow graft disruptions, which are quite a challenge in the field. So let's try and build this concept a bit more in detail. Now, before we build the clinical application concept, it's very important for us to realize, in terms of thinking about the timing of when an LVAD becomes useful in an individual, is to understand what is the pathophysiologic rationale that an LVAD fills in heart failure. And if you think about it, we, of course, first have to exploit the neurohormonal, cytokine, and growth factor pathways in heart failure with the use of disease-modifying therapy. But the LVAD fits into the mechanical stretch and strain paradigm when, in fact, there has been escape or refractoriness to the first pathway. And in fact, this mechanical stretch and strain model has been applied to what I consider and call Laplace therapeutics. Laplace's law is, of course, directly where the stress is directly related to the pressure and the radius of a sphere, and inversely related to the wall thickness. And we've tried to, of course, reshape the ventricle. It doesn't work very well. Cellular therapy and stem cell therapy is still in very much its infancy. But it's LVADs that really have been shown to save lives. And this is how we should think about them. So the key factor is, how do we detect the patient that has correctly transitioned from the right pathophysiologic construct to the need for a mechanical physiologic construct. And while there are a number of different ways of looking at it, there are mnemonics, I need help, etc., where people have been exposed to inotropes, for instance. I consider the message from an academic detailing that is required should be very, very simple. And I usually refer to the rule of 3 for timely referral. 1, if you have had recurrent hospitalizations for heart failure, and if someone has had 2 hospitalizations in a year, that's pretty bad. 2, if you're starting to demonstrate hemodynamic intolerance to neurohormonal antagonism, let's say you can't tolerate Entresto, you can't tolerate escalation of beta blockers, or need to actually down titrate these drugs. Number 3, if you're utilizing staircase diuretic use while your renal function is worsening to maintain a congestion-free existence, those are time points at which we must consider referral to an advanced group. There are 2 other precarious scenarios that I'll point out for you. The first is non-responders to CRT. And the second is people who are referred for MitraClip or other mitral valve interventions, but are deemed not to be candidates. And we'll try and focus on that in the clinical application a bit. The CHF study, which was done in Europe, is quite an interesting study. They looked at patients who were in CRT and ICD clinics, and they said, okay, about 1 in 10 of these patients have persistent advanced heart failure despite the use of CRT technology. And it turned out that amongst this group of severe heart failure patients, nearly a quarter had an unrecognized need for heart transplantation or left ventricular assist device. And even when these patients were approached by their non-heart failure clinicians, many declined due to uncertainty and lack of understanding. So the clinical application of the timing and of how we utilize this and how we approach patients has to be changed in our field. Well, there's always a question that, there are so many advances in medical therapy. Will they render advanced therapy obsolete? And for example, Entresto, SGLT2 inhibitors, omecamtiv mecarbil. Will these drugs change the landscape of how our patients behave with medical therapy? Maybe, but if you look, the LIFE trial, which was presented at the ACC and just recently published about a week ago in JAMA Cardiology, suggested that when sacubitril/valsartan is applied in patients who have almost reached the precipice of the rule of 3 that I pointed out to you, that it doesn't seem to work, that there are, in fact, parameters, territorial parameters of where this drug works and where it doesn't. Just today's issue of the New England Journal of Medicine has the full comprehensive Paradise trial that was run from our group here by Mark Pfeffer and Dr. Braunwald. And in fact, even that in the post-MI phase shows that it doesn't necessarily work unless a patient is transitioning into clinical heart failure. And so there are some parameters into which these drugs fit, and they may not necessarily mean that devices like LVADs are redundant or will be made redundant. Take the GUIDE-HF trial, which was just published in Lancet, presented at ESC, in which we used the CardioMEMS device to see if we could decrease mortality and heart failure hospitalizations. And when you look at the NYHA class 4 patients in this particular study, they did not appear to have any benefit whatsoever, even from this congestion relieving sort of diagnostic approach and interventional approach matched to that. The other point is that the current ratio of need versus use may be 10x, indicating marked underuse. So the point that I'm making here is that things have not really changed for this group of patients other than the introduction of LVADs, and that optimism and new technology are needed to move the needle forward. For example, if you look at the 20-year-old rematch trial now, where you see this pink or purple curve with the decline in those who are generally bound to inotropic support, the question is, has the survival of such patients really changed in the last 2 decades so that you can avoid an LVAD? Well, at least this single center study argues that it hasn't. In this particular group of 200 or so patients, while there was acknowledged the marked heterogeneity in how patients respond, it turns out that the median survival of patients bound to an inotrope, even if they're deemed stable, is only about 9 months. And it ranges between 3 months to 37 months. So there's a big group in the confidence intervals. And in fact, the 1-year actuarial survival is under 50% for these patients, and 2-year survival is under 40%. And we know that with current LVAD technology, the 2-year survival reaches 80%, even for non-transplant recipients and candidates. And so this is a doubling of survival opportunity in these patients that we cannot ignore with an LVAD, and needs to be moved to the field and the knowledge base where LVAD should not be thought of by our colleagues in the non-heart failure world as being end-stage therapy. We should abandon the use of the term end-stage heart failure. Now, of course, one of the big challenges in making the devices completely forgettable is the fact that they still have an external driveline. And we need to consider how to reduce this and fully internalize devices. And there are, of course, two competing technologies right now that are being introduced and looked at. The first is a TET system, or a transcutaneous electrical transfer system. And the second is coplanar technology. The Achilles heel for both of these technologies, in my opinion, is actually not in the TET system or in the coplanar system. And one could argue that perhaps this is a bit more involved because it requires a thoracic operation. But the real Achilles heel is the battery. And when you look at the battery, it's the battery technology that is really causing us a lot of problems. And until a major disruption in battery technology appears, it may not be that this technology becomes as commonplace as we think it should, although efforts are clearly underway to create less powered requiring devices where we can give patients a lot more hours of freedom during a day without being connected. Certainly, reducing driveline infections is important, but completely creating a forgettable interface will take some time in the field. Now, two other important points that I'd like to point out for you. The first is cost effectiveness of these devices. This has been a big challenge worldwide. For example, certain countries like the UK still don't allow or propose destination therapy like we do in the United States. Why? Because they're not considered to be cost effective. What I can tell you is that with the most recent experience from the Momentum 3 trial portfolio, that these devices have now just reached the point of where, at least in inotropic bound patients, we can be quite certain that they meet the threshold for cost effectiveness. Whereas in the non-inotropic therapy bound patients, they may exceed the thresholds that most countries consider as reasonable for cost effectiveness. And that's why countries that do have a surplus of money to some extent, like our country, we do allow for the use in destination therapy, which is going to be the most important chunk of use into the future. And we need to continue to do well. This is the reason why I'm mentioning the critical importance of clinical application, timing, and reduction in risk, and creating an evidence base in the pharmacology of post-implant support. The second point I'd like to make for you is transplant policies. And transplant policies have been a big challenge. As we've seen on October 18, 2018, we created a new US donor allocation policy for hearts. What was the result? There was a sudden decline in the use of durable support for bridge to transplantation, moving the entire field tilted towards destination therapy. So be it. No problem with that. And we will readjust over time. But certainly, health regulatory system policy changes have marked influences on our system. Now, I want to spend another 5 or so minutes with you on the notion of myocardial recovery and remission. And we have always thought of this as our holy grail, that, let's put in a LVAD and let's recover the heart. And what I am about to tell you is a bit more of a pessimistic stance, but let's see if you agree with that. Now, we know that we can see remission with most of the therapies, and these are getting better and better. And we always have patients who are super responders. For example, we see super responders to CRT. We're likely to see the same happening when we use quadruple therapy now to some extent, and that's great for patients. The question is, in the type of patients we see, do we see that? Well, I want to introduce the concept of the difference between elasticity and plasticity for you. If you look at this individual performing a pretzel-like yoga posture, not any of you would think that this person would have a hard time coming out of it, right? That indicates that this individual is quite plastic, that there is no deformation left after this person realigns herself out of this yogic posture. So it's important to understand that elasticity is like a rubber band. So if you stretch the rubber band and you release it, it comes back to its original shape without much deformation. Plasticity is like a paper clip, where if you start to open the paper clip and then you close it back, the paper clip may still remain functional. So it'll still act as a paper clip, but its deformation will remain. And there is, with almost any biological system, including the heart, an elastic phase and a plastic phase. And this plastic phase then reaches a fracture point, which is when we have traditionally considered a late stage use of mechanical circulatory devices. Now, the TREAD-HF trial, which was done in pharmacologically supported patients who seemingly had completely recovered their LVEF, so-called super responders, with little expression of adverse natriuretic peptide elevation, normal heart size, structurally looking normal. In these patients, diuretics were withdrawn first, and then guideline-directed medical therapy was withdrawn, and about half of these patients relapsed within 6 months. And funnily enough, 40% of those who relapsed had late gadolinium enhancement on CMR, but 60% did not. And so even imaging doesn't necessarily point us in the right direction. And you can look at this as the glass half full or the glass half empty, and how you as a clinician look at this data will tell you. But the point I'm making with this important data is that if you are older in age, if you are on a lot of heart failure medications for a longer duration of time, and if you have higher expression of natriuretic peptides, the chance that you would truly have recovery is low, and you're more likely to be in remission than in recovery. So this is important to keep in mind. And in fact, we have very similar data from our observations with the MITRA clip. For example, we have two trials, the MITRA FR trial and the COAP trial, one which shows a survival benefit, the other which does not. And is it because one enrolled patients who were more in the elastic region than the plastic region, while the other enrolled more patients who were in the more extended plastic region? I don't really know the answer to that because clinical phenotyping fails in these patients. But naturally, one can actually get some insight from the COAP trial, where if you include the patients in the COAP trial that looked like the MITRA FR trial, these were patients with larger ventricles, more remodeling, despite good medical therapy over time, and had lesser degree of severity of MR proportional to the degree of LV dilation, they actually did not have any benefit at 2 years. So there is some suggestion that we do need to work on picking up the right patient. And there are, I admit, certain situations, peripartum cardiomyopathy, tachycardia-induced cardiomyopathy, toxic insults from which patients can recover completely, Takotsubo, for instance. But in general, in advanced heart failure, we don't see much clinical recovery. And as we look at these patients in our registries, now granted, these are not patients in whom there's an intent to recover. These are general patients, but the rates of explantable recovery after an LVAD are only about 4% at 4 years. So it's not negligible, but it's quite low. And one of the big reasons that I'll point out to you again as to why this happens is because of retained phenotype memory of heart failure within the unsupported ventricle or the right ventricle. And in fact, in studies that have looked at gene expression, it has been shown that only 5% of the dysregulated genes actually revert to a normal LVAD supported phenotype of normal expression after hemodynamic unloading. And the extracellular matrix, for some curious reasons, can go in multiple directions and may even get worse. So there may, in fact, be a dose range of how much unloading is required with this. The restage trial was performed in about 60 patients. And in this trial, very thoughtful 4-stage approach to weaning patients was entertained. And what this trial showed is that about 40% of the patients enrolled were successful in being explanted after an LVAD support. But who were these patients? These were patients who were less than 60 years of age. The average age in the restage trial, which was published in Circulation, turned out to be in the 30s. These were 40 patients less than 5 years of age. The average amount of duration of heart failure was about a year and a half. And these were all non-ischemics. So these are not, from Bayesian standpoint, not necessarily representative of the general population that we care for. Another trial that tried to use mesenchymal stem cells during LVAD also failed to meet its surrogate endpoint of showing any remodeling improvement when bolstered with either a placebo or a mesenchymal stem cell in LVADs. So the future might be still ripe. We may have to do auto transplantation by decellularizing and recellularizing the heart and completely renewing its interface. But stem cell therapy is still quite challenged by the age, the number of cells, the number of pathways that need to be addressed, and its adverse effects. So let me conclude by pointing out that if we have to move the field forward, we have to actually show a lot of direction, not only to engineering, but to the pharmacology, as well as to understanding the substrate that we are treating itself. It's a necessary wedding of both clinical and translational perspectives that will be required, and we should not necessarily put the cart before the horse as we think through this. I'd like to end by pointing out that maybe AI and machine learning will inform us better. I still don't know exactly how they will help us incrementally from where we are, but certainly in smart, refined management of pumps, this would become an issue. And then maybe the next future of battery technology is massless energy storage or structural integration within the framework of devices. That may be the way to go. I don't know where this is going, but certainly the future is quite bright. Thank you so much for your attention, and I will stand ready for any questions and answers should we have time to do so.
Grand rounds and thoroughly impressive and covering the breadth of the field. I'm getting texts on my personal phone how much of a rock star you are. I'm sure people have called you rock star, superstar, but I greatly appreciate the elegance and the relevance actually in a lot of perspectives, not just at an individual patient level, but I think at your stature and leadership, it's a balance of the system level and the society level that was very beautifully put forth. I do want to remind our audience to submit questions through pollev.com and enter Methodist for you to submit any questions, and this is a golden opportunity to tweak and then peek into Dr. Mehra's mind. I'm going to start off while we're getting questions, and Mandeep, one of the areas that resonates with me based on my research area in our lab is the cardiac recovery paradigm, and I think you beautifully laid out some of the paradigms and limitations, and some of the things that we published a controlled setting mouse model of cardiac recovery, and it's fascinating to see that the morphology recovers, but there are about 300 to 400 genes which never normalize. So as you said, that the Dugman and Bud Fraser's phrase of remission seems to be true. My question to you is this area of bridge to recovery, BTR strategy, has also become a strategy for what we call today as acute mechanical support devices. And there is a plan or hope for the future if labs like ours envision our dream of having a purposeful recovery, and we call it purposeful recovery strategy because I believe that medications do promote recovery, but it's not targeted towards recovery mechanism. So you come up with this foreseeable future where you have nanogene technologies that can promote purposeful recovery. When that happens, how do you foresee the unloading by a durable VAD versus these projected temporary devices where you go home with?
Yeah. So you've asked, first of all, congratulations to you and your laboratory for all the great work that you've done. I've been watching with pride and been educated by all of the work that you and your group have done. Look, the future, in my opinion, is very, very bright because of the way in which you're introducing the subject. You've now lowered your expectations to purposeful recovery, and I really like that term. And the whole objective of my statement was that we have tried to use a threshold of recovery that's here, and maybe the threshold of recovery that we need to think about is here. So, for example, with the CADs, not the VADs, these temporary devices in the descending aorta, if they actually do promote improvement in cardiorenal syndrome, they may in fact be extremely important neurohormonal antagonists, in a sense, in patients who are otherwise refractory to the pharmacological approach that you see. And they may just require short-term signaling to switch back to what you call purposeful recovery paradigms. So I do think that temporary use of devices like this will be necessary before we move into durable support into the future, if recovery is the intent. On the other hand, I will tell you that in most of our patients in whom we put destination therapy intent, recovery is not necessarily what we see nor what we propose. And these are patients who have reached the fracture limits or reached the high plastic limits of moving the biology forward. So I think that the future is quite bright. I think CADs are going to be a very, very good way of promoting early purposeful recovery. And I love that phrase. I'm going to use it from here on.
No, thank you very much for your kind words. And talking about phrases, I mean, there were some very insightful terms that you have put forth. I will give credit to you and also borrow those from you. I think the concept of staircase diuretics, I have not heard that, but it's so true, and I think it resonates with individuals. And I think you brought up in that context, and there's some questions which are related to the appropriate timing of VADs, right? And then we talk about the INOMAX classification and this 5, 6, 3, 4. In the current world, what is your message to individuals? Are you a big proponent of saying we should VAD everybody in the INOMAX 4, 3, or where do you draw your line?
Yeah. So, one thing that you may have noticed in the talk was I alluded to the LIFE trial, which was just published in JAMA Cardiology. And, a trial like that gives us probably a very interesting way of thinking about the right timing. Why? Well, in the LIFE trial, it turned out that people who were tried on Entresto, about 30% of them developed hypotension and had to get off Entresto. So my take is that I think we should just wait. We should introduce pharmacological therapy. We should try to introduce pharmacological therapy. But when patients start to react in the way in which they reacted in the LIFE trial, at that point, we should immediately turn our thought process to considering mechanical support for these patients. Because the longer we wait, the worse they may get, and the chance of recovery may be extremely low in those patients.
No, very, very valid point. I think we have to know the limitations of medical therapy when you reach a phase. And in the same context, I think we have a question about MitraClip. And when you look at the MitraClip cohort, and maybe the field will advance, but the 2-year survival of people who got the MitraClip is also not stellar. So one of the debates that comes up is, should we be even doing MitraClip, or should we just do VADs in these individuals? And I think I've heard Lynn Stevenson point out the field will have to identify earlier cohorts. What are your thoughts on MitraClip appropriate utilization?
Yeah, so it turns out that the 2-year survival in the COAP trial in the MitraClip cohort was about 10 to 11 absolute percentage points less than in the Momentum 3 trial. The difference, of course, is that the survival with VADS is in patients who've reached the point of inotrope dependence. Now, what you're really pointing out is, should we just not do a MitraClips? No, I don't think that's true. I think we should try to do the MitraClip in appropriately selected patients. There are some patients who will tell you up front that, look, the LV has remodeled to such a degree that it's not even worthwhile to entertain that. But if you do meet the criteria, you should attempt a MitraClip. The key question is, how do we follow these patients? Sudden cardiac death is quite common in many of these patients after MitraClip is placed. And we need to basically insert a heart failure specialist into the clinics that are looking at MitraClip. Just like we have imaging, intervention, and surgeons in TAVR clinics, we need a advanced heart failure specialist in these clinics, managing these patients both pre and post MitraClip and following them. And I think that is what is required to improve the continual journey to success in these patients.
I think that's the systems of care, and I think heart failure specialists in that teams definitely makes a perfect sense. And that's probably the difference between the COAPT and the MITRA FR trial, the selection bias, right? So I think that's a very valid point. We can probably tweak your brain for the whole day, but in respect of time, I'm going to probably ask you one more question. One of the challenging population is the adult congenital population that we all deal with. What are your perspectives on the future of these pumps being designed for this kind of population?
Yeah, very difficult question that you've asked. There's a group called the Action Group that has come together to really address these issues in adult congenital heart disease. This is a group that is very difficult to deal with, and very often are non-candidates for this because it's the right ventricle that is most dysfunctional in these patients. And it's a very few of these patients who really qualify for a true LVAD placement, and even that is challenged by surgical techniques. I think the future will be fully implantable BiVADs in these patients, and for well-selected patients who can then be bridged to transplant, because these are typically a younger cohort of patients, and many of them, if successful with a BiVAD approach, could be bridged to transplantation successfully. And if we can get there, we first need a good BiVAD that we use, or a total artificial heart. We currently don't have that, but the BiVACore device might be one that I'm quite intrigued and interested in seeing how it creates a fit for some of these patients.
Well, thank you very much, and again, thank you for your time, and we greatly appreciate. I want to thank Dr. Mehra on behalf of our institution for his time, and Mandeep, it's always a pleasure to hear your perspectives. Thank you very much, and I want to thank all of our viewers today, and I want to again guide individuals watching the DeBakey Grand Rounds to the George P. Noon conference. You can go to the registration link and still live stream, and thank you, Mandeep. I will hand over to Dr. Guha on the other end to continue the George P. Noon conference.
Thank you so much. Thanks very much.
Bye-bye.